I am so excited to welcome you back to our second concurrent session. This is session 2.2, how to intervene or change behavior in real time. At Shatterproof, I think, in our work around stigma, probably the most common question I get asked is, when you do see someone having, a stigmatizing viewpoint or making a disparaging or discriminatory remark in your day-to-day life or in your workplace, what do you do to actually combat that? And I think sometimes the answer can feel, a bit abstract. So we've assembled this panel to really dig into that question and obviously many others. And we're really excited for the dialogue. I'm going to quickly just introduce our wonderful moderator, Dr. Elizabeth Salisbury-Afshar, the Associate Professor in the Department of Family Medicine and Community Health, the University of Wisconsin School of Medicine and Public Health. So happy to have you. I'll leave it to you to make introductions to our other remarkable panelists, but thank you everyone for being here today.
Thanks so much. Thanks for having us. And I specifically would like to thank the National Academy of Medicine, Shatterproof, and the Dell School of Medicine for hosting this incredibly important summit. The title of this session is How to Change Behavior in Real Time. And as I was reflecting on it this morning, I was sort of recognizing that there's always some self-selection in who attends, right? Sometimes the folks who probably most need to be here aren't the ones who choose to come. And the folks who choose to come are the ones already really working to improve behavior. That being said, even just in our preparatory call with our amazing panelists, it caused me to reflect. And I think we're hopeful that this session will make all of us reflect. And no matter what type of work we're doing, we can always do better. We can always push harder. We can always fight harder to deconstruct systems that are broken and that don't work and that are actively harming people who use drugs. And we can always push, whether within our own organization or just in our own self-reflection of the way that we approach things. So with that, I just want to say we really are happy that you're here, and we have three passionate, inspiring panelists that we'll be hearing from today. We'll go ahead and hear from Guy Felicella first. Guy comes to us to meet us from Vancouver, BC. It's always amazing to hear from our Canadian colleagues, where he is a peer clinical advisor and a passionate advocate in this space. So thanks so much, Guy.
Hi, everybody. Thanks for having me, and thanks for the intro, Elizabeth. Stigma is something that's really impacted me in my life of using drugs, and not only in just using drugs, but also now recovered from those drugs. Our society just doesn't make it easy on people to move forward, even if they stop using substances. I'm still looked upon as my past, as a person who, broke the law. Anytime I apply for insurance purposes, they look at my record. I've been denied specifically on my criminal history and past drug use for insurance purposes. That's not what I do today. Even my past still continues to haunt me. And if you have to actually look at the reality of ending stigma, then you have to look at where it was created and where it started. And it's really rooted in racism, in our drug policies and laws. And this continues to impact us as a society. It's that structural stigma that has fueled the population's views towards people who use drugs, which is killing people. And the stigma that exists in our society is just as deadly as the drugs themselves. And any life lost to an overdose is a policy failure. And yet we just haven't done enough to change policies. And now, even in today's times, you still feel this discrimination and stigma that exists in all our systems of care. As a substance user, when I needed help the most, and was struggling in my life and walked into a health clinic to ask for help, they looked at me as a drug-seeking individual that was seeking substances. Of course I was seeking substances. I was in withdrawal. I was asking for help. And yet they turned me away because I am a drug seeker, a drug user. And who didn't turn me away? Well, the drug seller. And so if you really truly want to replicate a system of care that supports people who use drugs, then you're going to have to compete with how low barrier it is to access these substances on the street. For people to line up at a clinic or to go to a pharmacy every single day or to see a doctor once a week for urine screens, this is not normal. This is not normal practice in our society. But for people who use drugs, this is the reality. We don't give people any hope to move forward. People are homeless, people are struggling with poverty, and yet we expect them to show up at our facilities and follow our rigid rules and policies. And then we blame them. We blame them when it fails. And yet we are never held accountable. Our health systems are never held accountable for its failures in addressing people who use substances. And then on top of that, if you want to talk about mass incarceration of people who use drugs, just for being a drug user, imagine just for being a drug user that you're incarcerated just for using those drugs. Now, if you look at people who struggle with a substance use disorder or an addiction, it's rooted in our trauma. And if that trauma is not ever addressed, we blame or we stare at the substance use. The symptom is why people use drugs. We do not do enough to address the trauma that people are struggling with. And then we cause more layers of trauma on that individual with our systems of care. And we wonder then why people don't reach out and ask for help. If you go through the system once and it's rigid challenges and loopholes and jumps and urine screens and stigmatizing and criminalizing questions and being incarcerated and looked upon and judged as being a substance user, and then try to move forward with your life, and you get through that once, tell me you're going to do that again. And you wonder why people don't show up. I mean, I look at, the lineup at a methadone clinic. It is very stigmatizing for people. People need freedom. And if we need solutions that give people the freedom, people deserve carries, people deserve dignity, people deserve to have the healthcare that everybody else has healthcare. It's not a radical solution to support people who use drugs. There's nothing radical about it. It just should be healthcare. We discriminate on our healthcare of who is getting this full spectrum of care and who's not. If this was any other health condition, there would be a massive support system in place for people. And we just have failed miserably in addressing that. And one of the things that needs to change is our policies and procedures. And if we truly are serious about removing stigma from our society, then we need to have vital harm reduction services such as syringe access, supervised consumption sites for people to use drugs in a place where they're welcomed. I kind of described the supervised consumption site in downtown east side of Vancouver, kind of like Cheers, norm. I'm the norm of the supervised consumption site. When I walk in there, everybody knows my name and they're very glad that I came. And it's that kind of environment. It's no different from walking into a bar or walking into a supervised consumption site. And if people often think, well, this enables people to use drugs or harm reduction enables people to use drugs, people are already using drugs. Like, it's not because of harm reduction that people use drugs. They're already using them. Harm reduction actually saves people's lives. This vital health services, the recovery that I have in my life today, doesn't exist without harm reduction. I survived the first dueling public health emergencies here in Vancouver, which was the HIV/AIDS crisis, where 1 in 4 were infected with HIV/AIDS. I survived the overdose crisis in the 90s. I've survived 20 years of being homeless. I've survived 6 overdoses from 2012 to 2013, where I had to be brought back to life 6 times. I survived all this, and I'll tell you why. Nothing exists in my life. This conversation wouldn't exist if harm reduction didn't exist. And if harm reduction didn't exist, my recovery wouldn't exist. My children wouldn't exist. None of my life exists without this vital tool of harm reduction. Harm reduction meets people where they're at and supports them where they're at. And if we can continue to change and do that and to show up in substance users' lives, they're going to feel the support. This is a journey. Not everybody who uses drugs struggles with an addiction or a substance use disorder, but everybody who uses drugs is at risk of an overdose or a death. And these deaths are preventable, and these deaths are our policy failures. I hope this inspires you to look at yourself as a person and understand the roots, causes of our prohibition and our drug policies. And it changes your views to people who use drugs, because when somebody shows up to your facility, your clinic, it's not just you and him or you and her or you and them. It's you and them and every single bad experience that that person has gone through from the health authority. And if that's the one thing that you can remember, have awareness, listen to your patient and be patient, things will change. Thanks for listening.
And I should have mentioned, we will be having time for a Q&A at the end. So if for our participants and folks who are listening in, please feel free to go ahead and put questions in as they come up. Next, we'll be hearing from Laura Guzman, who is the Senior Director of Capacity Building and Community Mobilization for the Harm Reduction Coalition in California. Thanks so much for being here, Laura.
Thank you, Elizabeth, and thank you to the panel. I feel very privileged to be here. I've been working for the National Harm Reduction Coalition since February of last year, but I've been associated since 1995. And the National Harm Reduction Coalition actually was formed in part for all the reasons that Guy mentioned. In 1993, there was a gathering of actually activists, people living with HIV and drug users who for 10 years were actually neglected and dying in the United States because there was no focus, no public health focus or government focus on people who use drugs and were dying of AIDS. And just for context, for those of you who don't know history, in New York, 53% of all the infections in the 90s actually were, and people dying of AIDS were people who injected drugs. At this point, given all of the efforts by implementing harm reduction syringe service programs, less than 3% of people are impacted by HIV/AIDS. I like to say that, the National Harm Reduction Coalition has been now for almost 25 years providing training, technical assistance, policy work. We're now grant makers. And at this point, we really are focusing on creating spaces and dialogue. And I would say stigma is one of the first things that we do, because I think that what Guy is saying is not only changing individual perceptions, but actually changing systemic impacts of what we call racialized drug policies. So we are really focusing on not just changing stigma from an individual perspective, but really undoing all the violent systems that actually keep drug users, in particular poor drug users and drug users of color, hostage and colonialized. I want to say that I came to this work in the 90s, and I was blessed to have been invited to work in a hotel called the Ambassador Hotel, which, for those of you who don't know, there's actually a YouTube video called Life and Death in the Ambassador Hotel. It was one of the first places in the country that allowed people with AIDS that were dying to die with dignity. And so I was privileged to be taught by actually those pioneers. Many of them were social workers and nurses, actually, besides people with AIDS and drug users themselves. And so I had that first crash course on harm reduction and learning from the community that was, again, suffering and dying of AIDS with absolute no supports, to know what it meant to learn to understand all of the barriers that drug users faced, to learn about drugs. Right? I'm from South America. I knew a lot about cocaine, but I'll tell you, heroin was not in our repertoire. So I had to learn how to work with injectors, how to work with meth users. And actually, I would say, bringing the love, and that is very important for us in harm reduction. We really uphold the dignity and the human rights of drug users, but also we're thinking of this work as a work of love, and therefore stigma doesn't have a place. So I was very impacted by my first supporting, advocating. I was an outreach worker. I was all over the city working with the folks that, again, nobody else wanted to take care of. And so that's how, in some ways I bring my perspective through the harm reduction work as a critical piece, is to bring the love and to bring the very challenges that, again, are not just individual, but really are the systemic violence. So when we say reducing the harm, we're not talking just about reducing the harm of drugs, because in the what I've learned in the experience of people who use drugs and are impacted by poverty, and racism and incarceration, drugs are the least of their priorities. There are so many other things that make them feel so bad. And in that way, I think it's very important that we really take this big lens when we're talking about what it takes to do anti-stigma work, because it is undoing the very systems of violence like I mentioned. I also wanted to share, I think that it's very important that we also in this work seek the meaningful inclusion of people who use drugs, not just in treatment, but in all of the systems that touch our communities need to be involved. And this concept of nothing about us without us is really critical. And it's still, even within the harm reduction movement and in a lot of our systems, is something that we haven't prioritized, and we must. Because one thing I want to say about stigma, I learned from the communities I serve, is that not only stigma gets in the way, makes you feel really bad, it gets in the way of change. So if we're not prioritizing to stigmatizing drug use and the very folks who need actually the very support that the systems, like Guy said, impact them and actually create in some ways chaotic drug use that doesn't get treated, pain that doesn't get treated. Until we don't do that, it's going to be very difficult to change the tide. So the meaningful inclusion of people who use drugs in systems, it's really critical. I wanted to just, in finishing this first piece, is to mention that there is no harm reduction without anti-stigma work. So concretely, it's very important that when we talk about drug users, we know that people are beyond their drug use, right? That we treat them as whole human beings. That's why language is so important. So we actually shifted. I remember in the 90s, we used to say drug users, and now we say people who use drugs, because we learned that by just mentioning drug users as drug users, it really confines them to a very specific thing that actually most of us share. Most of us are drug users, but we tend to really just confine it to those folks. Same with addicts, and addiction is one word that we take very lightly, and we consider a very complicated definition that actually we don't think that people should ever be labeled as addicts unless they want, the person themselves chooses to do that definition. We also think that, in healthcare in particular, we're so obsessed with outcomes and don't see that process is the most important outcome, and the process of trust building, of actually making people feel comfortable and actually seeing that we're willing to help. And in a second, I want to talk about drug seeking, Guy, because we were just having an interaction with all of our syringe service providers about how do we defy that horrible term of drug seeking behavior, and rather focus on actually realizing that treatment providers may be doing compassion withdrawing or compassion withholding when they're actually not treating people with the medications they need, when they're not addressing their pain. So language is so critical. Or emergency rooms that says we're not giving any pain meds here, which is just cruel. In a medical environment where we're not prioritizing the very thing that people need is to address pain with drugs, and drugs that take care of that pain. So we feel that there are a lot of intersections between harm reduction and stigma that we need to address, and also to, again, consider, again, the big picture, all the other things, we call it beyond the needle and beyond overdoses, is the systemic violence that we still are doing in healthcare, we're still doing in treatment. We just did, we have one of our grant making initiatives in California. It's called the California Harm Reduction Initiative. We actually advocated for and won $14 million by the state of California to support syringe service programs, which is one of the first in the country. And this was advocacy by drug users and SSPs. And we just did actually a participant survey, about 500 folks who participated in syringe service programs, and we asked them what are the barriers to linking to treatment, in particular opioid. That's what we were asking for, although half of our folks also use methamphetamine. But what we heard out of the sample of responses, 50% says the big barriers are all your bureaucratic barriers and the poor treatment our communities face when they go to methadone. I think Guy mentioned that. Even in MAT treatment provision, even in buprenorphine, we're seeing that there's a significant divide between who has access to bup and who doesn't. And we know also that Black and brown folks are the least likely among with Native Americans to actually get buprenorphine, get hooked, get supported and stabilized. So we're hearing that directly from folks themselves. And I think the only other thing in closing I want to say is that I think that there's this tree of liberation that we talk about and the tree of stigma. And so as we advance this conversation, I'm inviting everybody to think about what are those root thoughts that you have when you talk about drug users, and are you consider them as trustworthy and honest and able to change and able to be as resilient as Guy described? Or is it in the back of your mind still your roots, where you're thinking are those what we call the tree of stigma, that folks are really not able to change, that folks are really not deserving of the treatment or pain medications that we have, or that folks are just, I really don't need to focus there because I don't think there is any hope. So I'm just gonna leave it with that to let Gilberto present. Next.
Thanks so much, Laura. Next, we'll be hearing from Gilberto Perez, who is the co-executive director at the Texas Harm Reduction Alliance. Thanks so much for being here.
Yeah, good afternoon, everyone. My name is Gilberto Perez. I use pronouns he, him, his, and él. As I mentioned, I'm the co-executive director with the Texas Harm Reduction Alliance, and I want to thank everybody for the invitation and the opportunity for being on this wonderful panel. I want to echo what Guy and Laura have been mentioning. I think the last thing that Laura mentioned about unconscious biases is something that we all have to think about on a day-to-day basis, especially when we're working with folks. As a brief introduction and background about myself, I am originally from El Paso, Texas, and had been focusing on harm reduction and binational health for the last 6 to 7 years or so by now, but got the opportunity to join Texas Harm Reduction Alliance of September of last year. And so I would like to share that Texas Harm Reduction Alliance really shaped and formed out of, racialized drug policies and all of the health inequities that us people who use drugs suffer on a day-to-day basis. I think that my background particularly is unique in the sense that, as I mentioned, I have done a lot of binational health work. And so whenever we're looking at communities, border communities, we really need to take into account the policies and procedures, and as well as the whole systemic structure of both countries. In my particular case, looking at Mexico and the US, because El Paso as a border community, we have a lot of interchange between our systems. And so there's a lot of differences, there's some similarities, but ultimately we have to look at both of those in order to make, to really deliver adequate healthcare services, because no big enough wall is gonna stop from anything, from folks coming back and forth and sharing in very unique and very meaningful experiences between border communities. And so that's a little bit about who I am and what I bring to the table. I did want to share and echo what Laura was mentioning about meaningful involvement of people who use drugs at every level, not only at the frontline level, not only hiring recovery coaches to do the work that is very much needed, but also involvement in strategy development, program development, and program execution and implementation. Through my work, I've done several community-based participatory research projects at both ends. One where researchers and principal investigators or heads of these programs only include people at the front lines or only tokenize people in order to say that they have involvement. And I've been participating in programs that really include folks in the whole context and really value their input and really hear out their voices and their experiences to help inform whatever it is that is being implemented or put into place. However, there is a larger problem here, and I think it goes back to the stigma around policies and regulations based on funding decisions. A lot of funding decisions tend to go through federal channels where grassroots communities-based organizations do not have access to these funds. And so a lot of these funds to help deliver meaningful programs are funneled in a way that make it very hard to deliver harm reduction services, true honest-based harm reduction services out in the community. They're often channeled through universities, research institutions. They're often funneled through academic settings. And that only imposes a lot of barriers and a lot of red tape at the institutional level and decreases access of who these monies are intended for in communities. And so I often find it hard, oftentimes I find it hard to fight on both ends of the spectrum as to, okay, we're challenging our systems that are further stigmatizing or that continue stigmatizing us and our communities, but at the same time, fighting for funds and making sure that there's meaningful involvement of community in our current system to move forward with program development and program implementation. And so a key strategy that I always bring to the table is having folks at the table from square zero, right? From step one all the way up to the execution of whatever it is that we're developing. So there's systemic stigmas that are at play here because they're not trusting of grassroots community-based organizations that oftentimes tend to be peer-driven, which makes the work that much meaningful. And so that needs to change, but there's also stigma, and then that alone also brings internalized stigmas that question self-worth, self-value, and ultimately impact our empowerment and our autonomy. As a first-generation Latino myself, I suffer from a lot of internalized stigmas of not being able to move the needle forward and create and provide systems that are actually meaningful because of all of my negative experiences with the larger healthcare system, particularly with larger governmental entities, and my experiences as a queer person, as a person of color, as a person who uses drugs. And so as my last point is that we need to value and respect each person's identities and hear them for what they're worth and take them into consideration, into account when really putting programs, when developing programs in order to also reduce that impact, the negative stigma of folks. Yeah, thank you.
So much to all of you for your comments, your stories, your willingness to share your own experiences. It's extremely powerful. One of the things I was struck by that each of you said, and I'm going to ask you to elaborate a little bit more, was, I mean, we talked, each of you spoke in different ways about things that need to change, largely around systems of care, but even more broadly, Gilberto, related to funding and research in particular. But, you know, when we think of systems of care, I'm really talking about everything from community outreach to syringe service programs to care received in hospitals and clinics to licensed sort of formal addiction treatment. And so I would ask each of you sort of when you think, so we know we've heard some of the things that are wrong with it and some of the reasons why, but when you think about what it could look like, right? When we try to re-envision what we would want, Can you say a little bit more about what that looks like? And you know, you can extrapolate on that however you think is most relevant to your own experience and work. But for the audience who may be working in some of those settings, you know, what are the things we should be striving for? And whoever wants to jump and pick up the mic first, I'll open it up.
I can go, Gilberto. Yeah, it's okay. I just want to say, I think that and you know, it was interesting to hear Gilberto talk about community, taking care of community, because I didn't say that, but it's very important to us, not only to have the meaningful involvement of people who use drugs, but this idea that community takes care of community better. And so I want to say that a lot of us have worked in you know, programs or developed programs. Myself, I directed for 16 years Harm Reduction Center in the Mission District of San Francisco, targeting immigrants and the neighborhood, not just people who use drugs, but people who are unhoused and at risk. And in our model, which it was a very beautiful weaving of not a lot of funding, but really a concept of community taking care of community. We had a drop-in center with survival services. So we had showers, we had actually laundry services. We served coffee in the morning. We had a clinic. We were a healthcare for the homeless funded clinic. And actually it took us about 16 years to get the wraparound services like a behavioral health expansion. And so what we did is had a very Latino-centric harm reduction program that was taking care and supporting people with their survival needs, actually fought for housing, organizing our community. We actually developed probably the only housing in the United States that targets undocumented folks, formerly unhoused undocumented workers, many of which were also impacted by you know, trauma and drug use. Many of them were from Central America. They're now elders. We had a peer model, peer-led, professionally supported. We felt that the peers had a much important role than the professionals in actually shaping how community engaged, whether it was in organizing community programs. We had tons of community programs. So we had Ladies Night was actually a model program for women who use drugs, and it was both for cisgender women and transgender women. We had a program that helped the community to pick up needles, you know, and make sure that we had a neighborhood policy so that the NIMBism was not that intense. We had an LGBTQ day. So we actually did a lot within our Latinx and the mission community. We always offer different ways in which our community will engage that trickle at some point in interest in medical care, sometimes interest in behavioral health support. And then we managed to have an addiction clinic. We started to do induction in Butte. We were also trying to see what other ways we could treat through the clinic. The other impacts of drug use. We actually did a pain clinic. We actually had pain contracts. We were actually given medicine for pain. And so to me, that was a very dreamy project where you're really integrating and then collaborating. We collaborated with folks who lived in SROs. We collaborated with Women Community Clinic that were doing all of our women care. So I want to say we have it. The key is, how do we make that sustainable? How do we believe community, taking care of community? And I want to say in San Francisco, in our rises of overdose, which, you know, San Francisco was actually does better than the rest of the country in terms of overdose death, but yet we've seen a double of overdose deaths since 2018. That also is double in 2000 probably, and 20. We don't have yet all the data. But we have a community-led naloxone distribution program, one of the oldest in the country, called the DOE Project. And as we had and suffered 699 deaths by overdose, the community, and when I say the community, I mean individuals, CBOs, we have a whole system of care. They reversed 3,600 overdoses. So that means that without community intervening, we would have had 4,500 deaths. And for us, that is very telling about how we have to really get community to lead, because community knows better. And so I just want to say that's, to me, sort of some of the ideas, things that we've done and guidance moving forward.
I think in harm reduction, there's really, if you look back at its original roots, there's two kinds of harm reduction. There's drug user grassroots activism harm reduction, and then there's this clinicalized, medicalized model of harm reduction. And they don't jive. And if we want to make a systems of care that actually endorses harm reduction, then you need to include people who use drugs in this system of care. Because if you don't, or you'll never be able to compete with the grassroots harm reduction. That is the true meaning of meeting a substance user where they're at. And so you're going to need to collaborate with drug user groups, drug users, to create a system that benefits people who use drugs in a way that supports them where they are. What the medical version of harm reduction has done is supported the medical system of where it's at. So it doesn't support the person who uses drugs. It's supporting a system. It's completely different. And this is why it continues to fail people. And then yet we blame people for its failures. It's rooted in our institutions. We have to look at ourselves. It has to be held accountable. And then we can move forward and support people who use drugs. And until we actually get there, you're always going to be seeing people access in a way that causes harm. And we spend billions and billions of dollars a year trying to keep drugs out of this country. And then we spend billions and billions of dollars reducing the harms of those drugs that weren't supposed to make it into the country, but yet they are in the country anyway. And so why don't we just end the war on drugs, take all that money and build in a system of care that supports people who use drugs and get people the support that they need? We could have this and really change the complexity of not only our societies, but the world. And if we get there, and we will one day, I just would love to see it in my lifetime.
I think you said it perfectly. I think that in comparing the true harm reduction efforts that were peer-driven, peer-led, grassroots, in comparison to what we're seeing a lot more now as harm reduction is being talked about more in more clinical medical settings, we're talking about embedding this system into something that's already in place and something that has failed us and that has failed people who use drugs for long periods of time. And so, I mean, my advice to my short advice, Elizabeth, to your question is to get out of the way, and let folks who know what's best for their health lead.
There's a question from an audience member that I think sort of dovetails perfectly to what we're discussing right now. And it says, can anyone speak to how they've included individuals who are currently using drugs? And I'm assuming they mean either in program development or in thinking about programmatic changes. And so they go on to say this may be important as they are the target of improvement efforts and are still left out. So I would love if anyone has a specific example to share on that note of how to do this.
In the program I led, basically our peer and professional staff had a lived experience of using drugs. And so it was very important to us as we're hiring our team. And again, not just our peer team, but even our managers. We had a management team of people who use drugs. And also it was, particularly Black and Brown, because we were serving the Black and Brown community. So we were also rooted not only in racial and cultural practices, but also in the community we serve, which was a very strong Latino community. I want to say that in our current work with SSPs throughout California, we're also amplifying what the meaningful involvement of people who use drugs means, because it's not just hiring folks. We have programs that actually do all of their program development based on the feedback of the participants. So there is a way in which you just check your program and see, exactly what Guy says. People who use drugs, define whether that program needs to be changed, shifted, etc. In our project, in our program, we were actually not only doing community meetings, but constantly checking, doing surveys and getting our folks to really, redefine, start a new program that were all always check with community. What we found is a lot of programs actually do very little check with community whatsoever. I mean, and not even doing formal surveys. So I think that for a lot of people in the audience, it might be just starting that little step, but meaningful involvement of people with lived experience should be considered very broadly. Including all the organizing and advocacy and policy making that oftentimes is just done by 2 or 3 people that have, a law degree or policy experience. So I will say in every possible way, defining meaningful involvement should be really broad, and actually should be also checked with, people with lived experience to say, what does that mean? What does it mean for me to have? One more thing to say is a lot of folks form advisory boards, and in Alameda County, we're doing that with youth with lived experience, and we decided to call it a youth action board. So it's what is the decision-making authority that any of your bodies have to really have that meaningful impact.
Yeah, sorry, anybody else? There's a few more questions, but if there's anything to add, please go ahead.
No, nothing really to add, but yes, valuing lived experience as part as the center of the program of the organization is also very important for us, not only in like frontline level, but also in leadership, in our leadership and within our board of directors, right? If our board of directors does not align with our organizational values, or if a board of directors is just white, cis people, and that's not representative of the communities that you're serving, especially if they don't have that lived experience.
Changing gears just a little bit, there's a question that came in, and I'll just read it. It says, we're seeking ways for medical students to be able to respectfully respond to attendings that stigmatize people with substance use disorders. Speaking truth to power for medical students is particularly challenging, especially in a dynamic where the attending grades the student. So a student could hear, for example, one of the head physicians say something that is stigmatizing, may want to respond, but doing so may impact their grade in particular. And so the question is, are there any resources or thoughts that you can offer that would be helpful? I would just add, I think this applies.
Do you want to chime in? I just want to see if Guy wants to chime in.
What's the question?
The question is about medical students in, like, let's say, for example, a lot of their work, their clinical work is in a hospital. And if they, for example, hear one of the doctors that's grading them, that's essentially their boss for the month, using stigmatizing language or speaking in a way that would be stigmatizing toward a person who uses drugs. Specifically, they're asking, are there resources or thoughts you have on how they could do that, sort of given the power dynamic?
Yeah, no, for sure. And it's very hard for, I do a lot of talks with medical students that run up with the same types of questions like that. And what usually happens is, unfortunately, is that you can't say anything. There needs to be something outside of that where you can file something anonymously as well, so that it doesn't target the person. But if we don't say anything, then what we are is complicit in allowing it to continue. It doesn't change anything. It's actually, a lot of the times, I remember meeting a social worker who told me that I don't help people unless they help themselves. And I actually thought to myself, I said, well, that is kind of the old guard of how it was in the 80s. And unfortunately, this individual should be immediately removed and severance packaged and move on, because you're not helping people if you're continuing to be judgmental or think that somebody doesn't want to have support. People want to be supported. The unfortunate thing is that we don't make it easy for them. And so for any medical student, sometimes it's also to even if you have to lie and pull the attendant over, the director or whoever your boss is, and pull them aside and say you were impacted by that conversation as being very hurtful, that you may have a substance user or someone who uses drugs that's in your family, or somebody who has died of an overdose or something like that. It's very, very important to actually call out that behavior, because who's at fault? Unfortunately, it's not the medical student, it's the person that has their biased and judgmental views. And that person needs to be removed and put at some other place where they're not training medical students. And I would actually call on the medical system to actually put people in place that have gone through rigorous practices with people who use drugs, and also people of color and indigenous peoples, so that they understand, also trans and LGBTQ people as well, so that they understand all the sensitive issues that are behind all of this, and so that there is no biases or judgments when training these students, because these students essentially are going to be the generation that replaces that generation. And so we have to do a better job at training the medical system, and that should be part of it. And I know that a lot of it, that training just doesn't exist, and it's really sad and unfortunate.
I want to put a plug, thank you guys, to say we're partnering in California with the California Bridge Project. And so we have a project where we have trained about, I think it was 50 hospitals in the first round, and now it's about 200 hospitals. And the training is actually, there's amazing toolkit. So I will put my email for the medical students so I can see if I can connect you with those toolkits. And the idea of actually investing funding, this was through the Public Health Institute, investing funding to train emergency rooms to work with folks that are landing in the emergency with a drug-related issue. And also we are funding substance use navigators at every emergency room hospital in California. Actually, we're training, we call them the super sons, but there are models that are evolving that I think, guys, so you know, we've been building some pretty interesting curriculum, and also really kind of mandatory training for emergency rooms in California that I think hopefully will slightly change some of the dynamics we're mentioning. But I also want to echo what Guy says. I think we should be unapologetic. I was one of those people that will call any hospital, any emergency room, any social worker that was working with my clients and make them feel bad, treating them badly, or said any shit that I felt was inappropriate, I will call them on. Any discharge that I feel it was inappropriate, like people who went, you know, because of alcohol intoxication and were let go within 2 hours back into our drop-in center. So any discharge mispractices. So I want to say, be empowered. We need to be unapologetic at this point.
We just have about 5 minutes left, and so I wanted to ask, I guess, just for each of you to give like any sort of last minute thoughts, reflections. This has been just a tremendous panel. I think we've heard, you know, and hopefully everyone here, like myself, has been reflecting on sort of what I can do better, what I can do more. So any last words, if you will, before we take a break before the final session. Gilberto, we'll start with you, if that's okay.
I guess the last thing that I would want to close off with was that we need to challenge ourselves and challenge the system around us at every level and at every turn. And by challenge, I mean looking at oneself, like looking at our internalized biases and how that impacts the people around us and people that we serve. And then systematically is questioning why funding channels are coming down this pipeline instead of this other, right? Questioning why people who use drugs are not included in this session, or why they're not included in this conversation, in this strategic planning meeting, or in this advisory council, if it ultimately is going to impact their health. And questioning our policies and procedures. I think this issue that was raised by a medical student goes very, very deep as to the lack of a system, of an accountability system by the medical institution, where that medical institution doesn't feel comfortable disclosing or just confronting that medical provider without fear of retaliation of some sort. And so this is deeper embedded of a lack of accountability. And so also looking at our policies and our procedures at that very level. So yeah, again, thank you so much for having me here, and appreciate it.
Yeah, thank you. Guy, do you want to go next?
For sure. So first, I think everybody should read Dr. Carl Hart's book. Start there. Drug use for grown-ups. And obviously, in order for us to remove the stigma that exists in our society, it's really simple. When somebody comes into your clinic or your facility, especially a person who uses drugs and needs support, go above and beyond to give them that support, and don't just tell them what they need. Ask them what they need. Ask them what they need from you. And when they say that they need to get on methadone or bupe or whatever it is, then you go above and beyond to make sure that that happens. And you go above and beyond to make sure that that happens immediately for the person. Because I'll tell you, if we can do that, just starting there, you know, it's simple words like, you know, be kind. It's really not that hard. And if you're not, you're actually pushing somebody to the illicit drug supply, where right now it's just that deadly. And yes, those drugs, OAT or MAT, they're not drugs that are meant to remove people completely from the illicit drug supply. But what they do is they give people the freedom to actually focus on other things in their lives, like family, housing, friendships, employment. Those are the types of things that we need to remember, that it frees up somebody's life. This shouldn't be a prison for somebody to live in for the rest of their lives. This should be freedom from the prison that we've put them in. Thank you.
That's beautiful. I just want to also close with liberation. And, you know, I started today talk about the tree of stigma and the tree of liberation, but liberation actually means that we are doing the work that it needs so people can feel free. And that means also that we create plans together based, again, on people's goals, as Guy says. And as someone that has been doing trainings on motivation interview, and I know a lot of people in this audience have trained on stages of change, I want to say, quoting Gilberto, start with yourself. Where are you in the tree of liberation versus the tree of stigma? How many times you're meeting with a patient and you just carry your own agenda? How many times you deny some specific, you know, filling SSI papers? I cannot tell you how many times I had to fight with doctors who felt that this person was not sick enough and could work, when all evidence showed this person was not going to be able to get a job. Can you help someone get on SSI and get extra income? And also, you know, ask clarifying questions. Be curious instead of being judgmental. That's the way, that's the place where we go first. All the ideas that I have in my head, the story I tell myself about my clients, rather than really truly listening to the story. And so to close again, I think, you know, let's move through a process of liberation for ourselves and from the folks that actually need that support. And I also feel, again, not forgetting love, because actually stigmatizing people is not loving. So thank you.
Thanks so much to this amazing panel. And I see Matthew came back on the screen, so I think he's going to close out the session. Thanks to all of you.
Thank you, Elizabeth, and thank you, Gilberto, Guy, and Laura. This was just truly an awesome panel. And I think we, you know, in our first set of sessions, obviously spoke a lot about where stigma was showing up, where discrimination was showing up. And I think this panel gave people a lot to think about on when it does show up, what do you need to do about it, and how can you sort of empower yourself to do better? So we're so appreciative of you all taking the time, and I think this will be a great resource for many moving forward. For those who are attending the summit, thank you. We know that many of you are taking time out of your very busy day to attend. So we wanted to build in a pretty lengthy break at one point so people can step away, eat, grab a coffee, do other work, take a nap, whatever it might be. We're going to come back at 3:40. There's just going to be one session taking place, so we'll all be coming back together. You'll be able to find that in the 1.1, 2.1 opening panel room. We'll have a really incredible set of an innovation session where we're actually showcasing 6 of our winners of our innovation process and doing some really cool work around anti-stigma and anti-bias work nationally. And then we'll be with our keynote, which are a few incredible speakers.